Hello everybody and welcome to my YouTube channel, that is Academics@Critical Care. And today we look into a topic which is little obvious, uncommon, that is importance of home health care for improving clinical outcome. I have been asked to speak on this topic in a conference recently held in Bangalore, and I thought to upload it in my YouTube channel. While going through the preparation of this topic, I learned a lot about the data that is presently available in favor of home care. So, what do you mean by home health care? When you talk about home health care, it does not mean sending the patient to home under the supervision of family members only. It means it's a structured, protocolized health system which was done under strict supervision of medical personnel. It is basically nurse driven along with family empowerment. So it is basically a replacement of long-term care unit present in the Western countries. What are the scopes for home health care in our country? Most important is post-discharge follow-up of ICU patient and give them a structured treatment for their faster improvement. Beyond that, it can be used for palliative care, can be used for stable patients on long-term organ support, and also for certain critically ill patients who have a stable organ support and they are not keen to be treated at a hospital. So when you talk about post-ICU care, it is really challenging and interesting area of critical care. If you look at the third international consensus definition of sepsis and septic shock, when they comment about ICU outcomes, specifically mortality, they mention that sepsis, that is the dysregulated immune response along with an organ failure, have an around mortality of 10%. When you talk about septic shock, that is sepsis with hemodynamic instability requiring vasopressor or with high lactate, that indicates a poor tissue perfusion, mortality jumped from 10% to 40%. It's a significantly high mortality. But are you aware of the long-term outcome of these patients? There is very limited data about 90-day mortality, 1-year mortality, and 5-year mortality among these subgroup of patients. And also, more limited data when you talk about morbidity and quality of life of these patients after coming out of ICU. This is a large database that has been collected from the claim data of a large German statutory healthcare insurance in terms of the long-term outcome of critically ill patients. They look at the data of around 84,000 hospital survivors of septic shock, sepsis, and severe infection from the time period of 2009 to 2016, over 8 years. Then they look at the 5-year mortality and the impact of post-discharge rehabilitation on outcome. And they have been found that 5-year mortality increased significantly in patients with septic shock, sepsis, and also in severe infection without organ dysfunction compared to their matched control who did not have infectious disease. They had also found that the rehabilitation facilities showed a significant improvement on 5-year survival. So, a specialized aftercare program may help to improve long-term outcome in critically ill patients after they get discharged from the ICU and hospital. What about the organ-specific morbidity? The most structured data is available for respiratory system, specifically for the adult SIRS and the MERS survivors. And their outcome has been evaluated up to 6 months of discharge and also beyond it. There are around 28 studies, and the meta-analysis has shown there are persistent lung function abnormality in terms of impaired DLCO, diffusion lung capacity of carbon dioxide, and reduced exercise capacity in terms of 6-minute walk test. But strangely, they also found the abnormality or the morbidity is beyond the primary organ. There is a significant psychological impairment in terms of post-traumatic stress disorder, depression, and anxiety. Similar data was also found from follow-up cases of ARDS who have been followed for 1 year and 5 years after discharge from the hospital. Similarly, the researchers found that the compromised lung function and also there's a reduction in the DLCO along with reduction in lung volume in the spirometric parameters. And they have also found these parameters, the respiratory numbers does not get normalized even after 5 years from the point of discharge. So basically, what we are looking at is post-ICU syndrome. That means that even after ICU discharge, these patients are living or surviving with a certain amount of morbidity, which is beyond the primary organopathology. There are systemic findings. So by definition, post-ICU syndrome means there are new or worsening dysfunction after critical illness in terms of cognitive function, psychiatric function, and physical function. Usually there is no definite time-bound period to diagnose it, but mostly they have been diagnosed early after the hospital discharge. There may be subtle finding that we need to pick up. The exact prevalence is unknown, but studies have shown that more than 50% of the patients after discharge from ICU suffered some component of this post-ICU syndrome. And there are newly acquired disability in terms of activity of daily living after 3 months and even when there have been follow-up for 12 months. There are new acquired abnormality, disability this patient has developed. So when you look at the different clinical condition related to post-ICU syndrome, there are mental health abnormalities like anxiety, post-traumatic stress disorder, and depression. There are physical impairment in terms of primary organ dysfunction like decrease in the pulmonary reserve. There will be neuromuscular abnormality, restricted physical function. And more concerning is the cognitive impairment in terms of executive function, memory, attention, and the mental processing speed. And in brain ICU study, the average incidence was around 25%. And they have found that this cognitive impairment can be compared with moderate traumatic brain injury or mild dementia. And all these abnormalities, clinical abnormalities, does not get resolved even after 1 year of ICU discharge. That means there is a component of this pathology persistent even after 1 year. And there are also challenges related to the family that is mainly related to the mental health. And these are anxiety, post-traumatic stress disorder, depression, and complicated grief. And so this families has been termed as a special family who need external support for their betterment. These are called PICS family or post-ICU syndrome family. Now, regarding these abnormalities, some of them require special mention. One of them is ICU Acquired Weakness. These are a group of disorder which encompasses patients with ill-defined weakness and poor mobility. It includes critical illness myopathy, critical illness polyneuropathy, and a combination of CIM and CIP. These patients mostly present with global limb weakness, but it is more pronounced in the proximal muscle group. And protracted stay, requirement of prolonged sedation, and liberal use of muscle relaxants, steroids, antibiotics like colistin increases the injury severity. And this muscle weakness and functional impairment persist even after 4 to 5 years when they have been followed. That means these are not fully reversible. Another very important and less addressed problem is the malnutrition. If you follow up the patients who are on mechanical ventilator, you will find a 60% of a significant number of patients receive less than 60% of their daily prescribed energy. We know that the targeted energy requirement and energy delivery in a critically ill patient should be between 60 to 80%. And when we are not able to deliver a certain amount of calorie and protein to this patient, then a cumulative energy deficit leads to poor outcome. And mostly it happens because of feeding intolerance, delay in the feeding to initiation of feeding, and there are multiple time of interruption because of maybe ICU procedures, maybe because of weaning trial, maybe because of the radiological interventions that requires nothing per month. Even when these patients got extubated after prolonged mechanical ventilation, sometimes they develop swallow dysfunction. As a result, the targeted calorie and protein may not be reached very fast. As a result, these critically ill patients lose nearly 15 to 20% of their total mass by the end of first week. And when they have been followed in ARDS survivors, we found that this 20% loss of the baseline body weight need nearly 1 year, 12 months to be regained in the previous function. Even if they have been regained, the quality of the muscle is not like the previous status. Now the new muscle usually have a higher fat and water content. As a result, these patients complains of subjective weakness and reduction in the exercise capacity, leading to poor quality of life. Now, what are the risk factors that will push a patient towards development of post-ICU syndrome? Some we have already mentioned. There can be other personal issues, maybe related to the socio-economic, socio-demographic status, like age, sex, living situation, marital status, age of the child patient. There may be personality related, like illness perception, mindfulness, optimism, and maybe previous health related status, whether the patient has a poor nutritional status, hearing or visual impairment, previous ICU stay, and these are not fully reversible. But some of the issues which are related to the ICU can be addressed and can be reversible to some extent, at least partially, if we deal them properly. So some are related to ICU admission, like emergency admission or not, ICU type, hospital type, duration of ICU and hospital stay, ICU treatment like diagnosis, comorbidity, surgery and complications, and patient's experience in terms of ICU mentality, delirium, restraint, bed rest, device-related self-removal, pain, and ICU experience. As I mentioned, very few of them can be addressed, but if these are possible, it is better we address them. I try to reverse them if possible, partially at least. And these risk factors can develop before the critical illness, like pre-existing cognitive dysfunction, pre-existing mental health problem like anxiety, depression, maybe pre-existing functional disability, that patients are very frail or have some cognitive impairment. They may be related to the critical illness, like incidence and duration of delirium, requirement of sedation, whether the patient is in sepsis, shock, hypoxia, acute respiratory distress syndrome, and some may be after the critical illness. Those are early symptoms of anxiety, depression, or post-traumatic stress disorder. Those have been missed by the ICU doctor or the internist while planning for discharge of these patients. So as a result, we are presently looking at a huge public health burden because of this post-ICU syndrome. Now we have a number of patients who has survived the ICU crisis, but along with presence of neuropsychological and functional disability. And this psychological and physiological disability has a significant negative impact on families' outcome and income. And not only about related to the patient, but also related to the other members of the family who has been involved in the caring of the patient. As a result, national guidelines for the provision of critical care has recommended that the patient should have access to an intensive care follow-up program at least 2 to 3 months post-discharge for ICU admission more than 4 days. So they have identified that even a small ICU admission of 5 days can have a significant long-term impact on the patient health and psychological condition along with the outcome of the family. But these are little theoretical concerns. Do you really have any practical data about how the family members feel when they are taking care of these patients with post-ICU syndrome who have a significant amount of disability? Data is little limited. There are around 25 studies, 19 qualitative, 4 qualitative and 1 mixed method. And they have looked into 3 parameters like health and well-being of the patients and family members, employment and lifestyle, and the caregiver's role in terms of activity of daily living, knowledge, skill, and adaptation to the role. They found that there is a significant and meaningful impact on the life of the caregiver in terms of psychological morbidity and social adjustment. Now, we understand that data is limited for post-ICU syndrome, but we can extrapolate our understanding from other subgroup of patients with similar need, that is elderly patients with morbidity. If you look at the caregiver's perspective, who are taking care of the old patients with chronic illness, we'll found that they also complaints of mild to moderate burden. It's specifically concerning when there is a functional dependency, multiple comorbidity to the care receiver, along with memory and sleep impairment that escalates the burden to the caregiver. Also, it further intensifies if there is with advance in age, male gender, if the caregiver is a spouse of the care recipient, and longer care of provision duration, and no assistance. Here the word no assistance is very, very important because eventually these patients need a structured program with a certain help to have a better outcome in terms of both the care recipient and also the caregiver. So basically, we are looking presently at a paradigm shift from caregiver burden to a caregiver resilience. And for that aspect, routine screening, different preventive measures for the skill building of the caregiver and the psychological empowerment, also for the different restorative service are very, very important and need of the hour. So we all know that prevention is better than cure, and so this type of morbidities need to be prevented as much as possible. We all follows the ABCDEF bundle approach, that is awakening and breathing coordination with daily sedation interruption and ventilation liberation practice, delirium monitoring and management, early ambulation of the ICU patients, family empowerment and engagement, along with optimized neurological outcome in terms of lighter sedation, avoiding hypoglycemia and hypoxemia. These are more or less standard practice in any of the good ICUs. And the data of more than 15,000 ICU adults has shown that when you follow a protocolized bundled approach for prevention of this morbidity, there is this lower likelihood of death within 7 days, mechanical ventilatory requirement and coma, as well as delirium, physical restraint use and ICU admission. And this improvement in outcome with follow-up of this bundle is happened in a dose response relationship. That means with increased compliance of the bundle, the outcome is better. Now we all know that home healthcare experience is very limited for critically ill patients, but this is much more structured for palliative care patients. There are multiple studies and meta-analysis has been done, and they have found 6 essential elements of providing palliative care at home. That is integrated teamwork, management of pain and physical symptoms, and holistic care, caring, compassionate, and skilled provider should be there to provide the support, timely and responsive care depending on the plan of therapy, and the family and patient preparedness in terms of the anticipated outcome. Though all these parameters are not applicable, but the understanding behind these essential elements need to be incorporated when we are providing healthcare to critically ill patients also. So what are the patient support presently we are looking at? There are 32 studies involving more than 700 patients, and they have divided this patient support into 4 pillars. That is informational, emotional, instrumental, and appraisal. When we talk about information, it means provision of information to address different problems of the patients. So you have to share the facts about the admission, progress, and the treatment related to the patients so that they can cope up with the long-term sequelae of their disease. Emotional means we have to provide empathy, love, trust, and care so that they can cope with confusion, anxiety, flashback, and in that situation, counseling and the community support is very, very important. Next is instrumental, that helps the different psychological and physiological disability that these patients have developed, like sleep disturbance, fatigue, pain, physical and cognitive disability, and they also need different support to improve their activity of daily living. And eventually, from the appraisal, we need to get provision of a structured feedback, affirmation, and social compassion so that we can improve the quality of service and we can assure them that we are trying our best to provide best quality of support to the patient and the family. And as I have already mentioned, this process have to be started early, even when the patient was admitted in the hospital or when we are discharging this patient from the ICU. This is very important, and we have to follow up this patient in the community, especially in the initial few months of first 2 to 3 months. And there need to be follow up with a multidisciplinary team involving internist, specialist provider, social service, occupational and physical therapist. In that regard, some hospitals also have a PICS clinic, that is post-ICU syndrome clinic, when the critically ill patient has been followed up for these problems, and they mostly need to establish an ICU recovery program to have an overall better outcome in this subgroup of patients. There are different screening tools that has been used for picking up long-term cognitive, mental health, and physical functions. We don't have to follow anything specific. We can have our own protocol because the data is not robust for all these coding system, but we have to have a structured process to follow up these patients. But what about the real life outcome? There are some small studies. One of them I can like to quote here that involves 100 home care patients. They have been followed by WHO Health Organization quality of life scale, and they look into the activity of the daily living and the instrumental ADL after once they have received support for nearly 60 days or 2 months from the trained staff, and they have found that there's significant improvement in the overall quality of life, general health of the patient, but also most of the quality of life domain in terms of physical, psychological, and environmental factors. But if you look at the meta-analysis, Cochrane review and meta-analysis, they have quoted as there is insufficient evidence and limited number of studies. So this indicates we need to focus on to get data in this aspect, and we need more structured study to streamline our home healthcare services for the betterment of the patient. Now, beyond that, some studies has addressed patients who are little critically ill, and they have provided home hospital support along with nurse and physician home visit, intravenous medications, continuous monitoring, video communication, and point of care testing. These are small studies involving only 20 patients, but they have found there's a significant decrease in the median cost, nearly as by nearly 50% compared to the acute episode related to hospital admission. Home patients have fewer laboratory tests ordered and less often receive consultation, and they are more physically active and have a better sleep. There is no documented adverse event in this subgroup, but it is obvious that we cannot extrapolate this information for our critically ill patients who need ICU and ventilator or other organ support. Probably these are the patients who are probably on minimum or no organ support, need close monitoring, and in this study. Another important aspect of providing critical care support at home is telerehabilitation or telecommunication. Now, initially, it was started for the neurological patients who need long-term care at home, but now this telecommunication has been structured and revamped because thanks to COVID, now there are international guidelines and recommendations how telecommunication should be done. And once we extrapolate this information and use this information for better service to our homebound patients, I think the outcome is bound to improve. And also, what is the future? In future, probably we are looking at more advanced organ support equipments like maybe ventilators with a closed loop and a better alarm system who can change its setting depending on the requirement of the patient and raise an alarm whenever it is needed and need to involve the specialist or the doctors for the service. So to conclude, now presently we have a very limited data for home care services and in terms of outcome, but there is a huge scope as there is a progressive improvement in the ICU outcome and decrease in the mortality. So we are going to have a lot of patients who are ICU survivors with a limited disability of the pathological organ, maybe psychological and physiological abnormality. So we are looking at a large patient population who need this service probably at home care level. So what we need a structured patient-centric approach so that we can provide best supportive care to the patients, both in terms of physiological need and also in terms of psychological need. And eventually, probably, it can address the cost-related concern that we all have regarding the present healthcare system and also regarding the ICU. By this, I'd like to conclude my presentation. Thank you, everybody.